Hi, everyone. We're happy to have you here today. We're still getting a little bit of things running for the setup, so I apologize for a few more minutes. Hi, everyone. Thank you for your patience. Just a couple minutes. Okay, I think we are going to go ahead and get started.
Good morning, and welcome to our second annual Global Cure for Sickle Cell Disease Community Day. We're excited to continue the partnership we're starting between the global sickle cell disease community and the doctors that are trying to understand what happens to children and adults after they receive treatment to cure their sickle cell disease. My name is Reginald French, and I serve as the president and CEO for the Sickle Cell Foundation of Tennessee. As you know, multiple studies are taking place with the goal of curing sickle cell in patients who are experiencing sickle cell disease. Some of the studies involve patients and their family members to donate the bone marrow cells. And those family members can either be a brother, a sister, who is a complete tissue match, or a parent, child, or half-match sibling. Other studies use bone marrow cells from the patients who are collected and processed so the bone marrow cells can be given back to the patient with the goal of producing healthy cells. While we're excited that so many potential cures exist, patients, their family members, and doctors do not know which type of cure is the best option for each patient. Before that decision is made, we need to know a lot more about how each curative option affects patients, not only right away, but also many years from now. I contributed to a grant that was funded 2 years ago to study how these different curative options affects patients in the long term, with the research focusing heavily on heart, lung, and kidney health effects. Last year, we started this event with the primary goal of starting a dialogue with individuals with sickle cell disease and their loved ones to learn and discuss the main concerns individuals with sickle cell disease have about health after a transplant has been completed. We heard from individuals with sickle cell disease from around the world and found that in addition to heart, lung, and kidney health, there are significant concerns about pain, mental health, and fertility after transplant. We have planned today's agenda to address the community concerns specifically. We will hear from doctors who treat sickle cell disease and individuals who have been cured about their fertility, mental health, and pain experience before and after their transplant. Before I introduce our first speaker, I will pass the microphone to our meeting coordinator, Kristen Wachek, who will briefly describe how and when to use the different functions in the webinar. Kristen?
Hi, everyone. I just wanted to check in briefly to say that I'm still figuring out certain things. So let me see here. So hi. Yes, I am helping with the technical details, and I am hoping that everything will go reasonably smoothly. So this is going to show you, right, so we've got a few things going on. We've got a Q&A box where you will be able to ask questions. You can put a question in that Q&A box at any time. There is a chat. You're welcome to just check in, say hello. If someone's saying something, that you really like to hear and want to say, just say any positive feedback for our speakers today. You're welcome to use the chat. Also, if there's any issues, you can please message us, the hosts and panelists, to assist you with any technical issues. There's a raise hand function. So the meeting today, we're going to have, our speakers share their different stories and experiences, and then we're going to have a combined Q&A session after that. And if you want to ask your question live, instead of putting it in the Q&A box, we'll ask you then to raise your hand so that we can unmute you and allow you to share. That is the majority of what's going on. If there's any issues, like I said, please message me in the chat. And I'm also now about to begin recording. So that will be, I think that's all I've got. Take it away, Reginald.
Thank you very much, Kristen. So now we begin with the first talk, and the topic is fertility after transplant. Dr. Lydia Pecker, the director of the Young Adults Clinic at the Johns Hopkins Sickle Cell Center for Adults, and with research focusing on fertility in women with sickle cell disease. Ms. Charlena Station is a previous sickle cell anemia disease patient who received a stem cell transplant in 2019. She experienced the last 3 years without the occurrence of any crisis or pain episode. She underwent fertility preservations prior to receiving any chemotherapeutic and radiation treatment as part of the transplant process, and is here today to share her experience with you. Marquise Moore is a sickle cell disease survivor who received a stem cell transplant to cure the disease. He is the father of a 1-year-old healthy baby boy. Congratulations, Marquise. He made the choice to use sperm banking to have the option of having more children in the future and wants to help make other people aware of the importance of this option for transplant recipients. Welcome and good morning to each of you.
Good morning.
Hi, good morning.
Morning, everyone.
I'm Lydia Pecker, and I was going to start this session by just providing a brief overview about fertility in sickle cell disease, and particularly with attention to after transplant. And I've titled this a fairly nuance-free position because one of the challenges in describing the risks for infertility or preserved fertility after transplant is that we don't have a huge amount of data. But we have a lot of good reasons to think that fertility could be compromised by sickle cell disease. And so I just wanted to, by curative therapies for sickle cell disease. So I just wanted to share a little bit about that, my perspective on that with you all this morning before we hear from our panelists, Ms. Station and Mr. Moore, who obviously have really powerful insights about the experience of doing fertility preservation before pursuing curative therapy for sickle cell. Next slide, please. My disclosures are that I'm a consultant for Novo Nordisk and Global Blood Therapeutics. Next slide, please. So one thing that I think is important to establish is that when you're thinking about whether to pursue curative therapy for sickle cell and you're thinking about particularly the fertility risks, I think it's important to remember that sickle cell disease itself and some of its treatments may compromise fertility. And so this is how I've been thinking about fertility risks in sickle cell disease over the last few years. The first is that sickle cell disease itself is, of course, a risk to compromising fertility. It's an infertility risk. And that's because, as many of you know, the disease is associated with complications that can prevent daily life activities like having normal sexual relationships and other aspects of life that are required to make a baby. For women with sickle cell disease, we're learning about how the disease and treatments affect the ovaries and are associated with changes in egg supply. And for men with the disease, we also see that sickle cell disease itself and some of its treatments can affect sperm counts. And this is important for thinking about fertility preservation because what you have to preserve will be based on the disease and also your exposure to treatments. So there's a lot of outstanding questions about how sickle cell disease treatments affect fertility. This includes the medicines we use for supportive care, like opioid medications, Tylenol, NSAIDs, all of those things we think about when we think about future fertility. Hydroxyurea, we certainly think about whether iron can impair fertility because of iron deposition in the ovaries or the testicles, or because of just how it affects the blood is not yet established. And we don't yet know anything about the new therapies, voxelotor, crizanlizumab, and L-glutamine. We have a little bit more information about the risk for infertility with preparative regimens for cure. And that's just because these agents have been used not only to cure sickle cell disease, but have also been used to treat cancer and to perform bone marrow transplants for other groups of patients who have different disorders. And so the reason that fertility is potentially compromised in sickle cell cure is because all of the regimens use alkylating agents, and we hope someday in the future this won't be necessary. But at the moment, all of the regimens for cure use alkylating agents, and some of the regimens for cure also require irradiation. Next slide. So I think it's really great news for our community that fertility has become a sickle cell concern. This is a reflection of the fact that people are living longer and better with their disease. But of course, it brings up new complications. And so it's really important that everybody gets personal and individualized information about fertility. We can't really make blanket statements about your personal risk for infertility. Some of the things that factor into considering your infertility risks are your age, the kind of sickle cell you have, what kinds of treatments you've been exposed to, and what kinds of disease complications you've had. And then, of course, fertility may be more or less relevant to you based on your family building goals, plans, and hopes. And for people who are post-pubescent, so have already achieved puberty, that's girls and women who are menstruating, and young men who've achieved pubertal stages, sometimes the semen analysis or ovarian reserve assessments can help figure out where you are in terms of your fertility. And we're still learning more about how to use those tests in care. And so it's important, if this is a concern for you, that you're talking to your doctor about it to get the information, again, that's individualized to you. And we know that access to fertility care is a major challenge for our community. We're not the only community affected by barriers to fertility care, but one of the barriers to getting people to getting these analyses done and to getting to fertility preservation is cost and specialists available to provide the care. Next slide, please. And so I just wanted to make sure that everybody on this call is aware that there is, for the first time ever, a sickle cell disease fertility preservation grant available for people who are going through transplant. And that's because the costs of preserving sperm or banking eggs can really be quite overwhelming. And so the Sickle Cell Reproductive Health Education Directive has partnered with Be the Match, and you can go to the website and learn more about how to apply for a fertility preservation grant if this is something that you need to do before transplant. Next slide, please. I wanted to just be really clear that in the context of transplant, that these two things, the alkylating agents and the irradiation, are the two things that constitute infertility risks for this disease. And again, that alkylating agents are when you read the guidelines about infertility risks for children being treated for cancer, anybody who's exposed to an alkylating agent is considered to be in the future at high risk for infertility. And so that's sort of the basis for my opinion that everybody going through transplant should be offered fertility preservation and should be considered at risk for infertility. Whether that will actually come to pass or not is not established. Next slide. So sperm banking considerations. So first of all, the testicles can be shielded from irradiation. So if your bone marrow protocol requires irradiation, the testicles are shielded with a lead blanket so that they're not exposed to irradiation. And that's good for protecting sperm. People who take hydroxyurea and are considering sperm banking may need to stop hydroxyurea to let sperm come back so that sperm collection can be optimized. And because sickle cell disease also can cause sperm abnormalities, even after hydroxyurea is discontinued, it's possible that multiple collections of sperm will be needed to optimize the number of sperm that are banked. And as you're thinking through this process of banking sperm, the cost of long-term storage needs to be considered. Next slide, please. For women, and girls, it's a little bit different. So first of all, ovarian tissue or eggs can be harvested for fertility preservation. So for men and boys, only sperm banking is a standard of care for fertility preservation. But for girls and women, both prepubescent and postpubescent girls and women can have a standardized option for fertility preservation. Unlike the testicles, the ovaries cannot be shielded from irradiation. And so it's more, they're more vulnerable to the irradiation damage if your transplant protocol requires irradiation. Whether or not to discontinue hydroxyurea use for people who are going through egg harvest is not established, and that becomes a personal decision and a conversation between your care team and your doctors and yourself. And the medications and process, which Ms. Station is going to talk to a little bit more, is a little bit more complicated for women because you have to take a series of drugs to stimulate the ovaries to make your ovaries make more mature eggs than they would during a normal menstrual cycle. And those medications can be costly if they're not covered by insurance. And they also follow a particular order and sequence. And so most people, no matter whether they have sickle cell or not, who are going through an egg harvest, have a care partner who helps them stick with all of the different regimens as they walk along. And not only is there a cost associated with harvesting the eggs, but just like with sperm, there's a cost with storage for the eggs. And so that's a brief overview of how egg harvest or embryo banking can go. Next slide. And so mostly I wanted to stress to you that fertility preservation exists for men who are post-pubescent, so we can bank sperm. It exists for girls and women who are pre and post-pubescent in the form of ovarian tissue and egg harvest, and that those processes involve a number of specialists and a number of personal considerations, and sometimes, unfortunately, personal resources. And to hear more about that, we're very, very lucky to have Mr. Marquise Moore and Ms. Sholana Station here with us, who've been through this and are willing to share their amazing perspectives and their decisions around pursuing fertility preservation before pursuing cure for sickle cell disease. Thanks. And I think Ms. Station was going to go first.
Hi, good morning, everyone. Is everyone able to hear me okay? Okay, great. So personally speaking, as you guys know from my introduction, I've received curative therapies for sickle cell disease and the stem cell transplant process. In particular, as Lydia spoke on, this process involves the alkaline agents, the chemotherapy, and the radiation. So my experience was, before I entered that phase, I wanted to embark on trying to preserve my eggs for my future and the possibility and options of becoming a mother and parent later on in life. With considering that, my quality of life would be improving, seeing that I was going through the stem cell transplant. So to begin with, like Lydia said, you're assessed. So you're given a regular physical female exam, and you're monitored and looked at to see how is everything going on internally. After that initial assessment, then you begin to say, okay, well, working with the care provider to receive these hormone therapies, the different injections. My experience with the hormonal injections were nothing that was really kind of out of the way. I experienced the normal things that I think a person would experience receiving an extra amount of hormones. You're hungry, you're tired. I did experience some minor bloating in the stomach area as the eggs were beginning to mature. Nothing really out of the way as well. And this was over between a 7 to 14-day period. And I was also being examined throughout this process as the eggs were maturing. So receiving the injections with the care provider, getting into these appointments, experiencing all of this within a 2-week period. Then once they were finally mature, you have the actual removal of the eggs. And it's just a simple anesthesia procedure that a normal patient would have receiving a colonoscopy, is what I could compare it to, although you're not cleansing your system required for the colonoscopy. So after the eggs are removed, then they are assessed based upon grade. So I was able to bank 13 grade A and B eggs. And so they have been stored in the freezer, and I have the option to use those at any given point in time, whichever way I see fit. So if I myself want to carry any of those eggs, if I want to pursue someone else carrying those eggs, all of those options are available to me to be able to become a mother and a parent, given the fact that I've gone through this transplant and my quality of life has significantly improved. So I think that making this standard across the board is something that every woman and man should have, should be available to receive. We are going through curative therapies. We're bold, we're warriors, and we're trying to improve our life. So we want to say, okay, what are my options? And this particular fertility banking is a way of having insurance. So I will let Marquis speak on his experience now.
Thanks.
Hello, can everyone hear me?
Yes, you're great. Sound great.
Hi, thank you, and just thank you for having me. I would like to touch up on sickle cell patients and actually thinking about families in the future. I know for myself, just from my condition, I didn't think I would ever be able to have children just because I couldn't keep up with them. I was in constant pain. So now there being a cure, you being able to live a full life, I feel like every patient should look into banking or preserving their eggs, just anything that you can. Having a family is a wonderful thing. I have a 1-year-old, and I love the time that I can spend with him. Every day is amazing. Me and my wife decided to look into banking because we always wanted children together. We looked into it shortly, a little bit before my transplant date. The banking company, we called them, told them, hey, we wanted to preserve, X amount of vials. You can choose how many vials you would like to preserve. Each vial is about one child. So we told them X amount we would like to preserve. They mail you a kit. You put your sample in the kit and just send it back. It's pretty simple from a male's perspective. But I definitely would like to let every sickle cell patient know that it's a beautiful thing to be able to have your child and not be in that constant pain all the time, just to be able to do simple things, go to the park or, go swimming. You should definitely look into preserving. It's extremely important.
Thank you both for providing that beautiful overview of your decision. Mr. Moore, could you talk a little bit about, you chose to do your sperm banking sort of external to where you got your transplant, right? Could you talk a little bit about how you identified where you were going to do your sperm banking and the logistics of that?
Well, me and my wife did a little bit of research on, where we would like to preserve at. So we came to the conclusion we wanted to choose a company. They're located in Arizona. And roughly we did the thing where, do we want to have one more child? Do we want to have two more? So, that number just constantly keeps changing, but we had a set number that we would like to be at for the future. And that's how we came to that conclusion. Totally, we decided to save 2 vials. So that'd be 2 kids we could have in the future. And roughly it was about 1,100 altogether. They preserve these vials for 10 years, I believe. Great.
And so for clarity, you don't pay a monthly or an annual fee to keep your sperm banked. You've paid for a 10-year upfront fee. Is that correct?
Yes.
Great. Ms. Station, would you be willing to talk a little bit? You also had a unique kind of fertility preservation experience because you were at NIH, right? Will you talk a little bit about that, the logistics of that with us, please?
Sure. So my experience working with NIH, I spoke with the different physicians there, and they were able to design a protocol to offer the fertility preservation. And so they worked with Walter Reed Hospital. I believe it's directly across the street from NIH. So the way that it worked is I was seeing the gynecologist at NIH and working with them, and the actual procedure where I needed to go in for the removal was done at Walter Reed Hospital. And so that banking place, at Walter Reed is where my eggs were stored. And so initially it was about 3 years that was offered to me without any fee. And then after the 3-year period, I pay an annual fee to keep them frozen.
Terrific. Are there other things that have occurred to you that you think everyone should know?
Well, again, I can't express the joy and just the excitement of being cured, being able to get up in the morning and just cook breakfast and be there for my son. I like to spend pretty much all my time with him. My wife says he's getting a little spoiled, but I believe I earned that. So definitely, if you have the ability, if you have the resources, big thanks to Be the Match for granting sickle cell patients. Just please look into it. I understand having sickle cell is extremely difficult. A lot of patients don't think past, the pain, but you're going to get past the pain. You're going to have a life after transplant. Just make sure you preserve that life so that, you can have one with your family. It's a beautiful thing to be cured, but it's even better to be cured and then spend that time with your family.
We have a question in the chat that I wanted to put to both of you, which was that someone asked if you could talk a little bit about the condition of your health before you went through transplant, which, right, probably affects a little bit the extent to which you feel like you can go through something like fertility preservation. And the person is specifically asking about what treatments you were taking for sickle cell disease before you pursued fertility preservation and transplant.
So I will go first. I pursued hydroxyurea initially, but I didn't find that it was really working that well for me. And I would say going into my young adulthood is when my crisis would begin to occur more frequently and more major, and the length of time would become more. So I think, honestly, I had good pediatricians. I had good care overall, good health overall, no really outside conditions related to the sickle cell disease for my physical health. And I think that's one of the contributing factors that made me a really good candidate for the stem cell transplant. But coming up into the stem cell transplant in the process, my crises were a bit more heavy and severe and so forth. And then I also pursued like the transplant, the blood every month that you're receiving. Yes. Thank you, Lydia. And so that was also a help for me as well, outside of the opioids.
Mr. Moore, you want to talk a little bit about what was going on with you before transplant?
Definitely. A big thank you to Dr. Pecker. I can't stress that enough. When I reached out to Dr. Pecker, I was going through, to say the least, chronic pain levels about 8, 9, 10. It was just all day. I was not able to really get up, make it to the bathroom, to be honest. My wife had to help me with that. It started roughly about 23. Within a time span, I'll give it 5 months, my health began to decline rapidly. I went from, working to I wasn't working anymore, to I had to be in the house most of the day, to, couldn't cook anymore. So I had to be in bed. So when I reached out to Dr. Pecker, I was definitely going through a rough time. I've tried hydroxyurea. It didn't work for me that well, not to make a meaningful difference. I was on Ixbrita as well. Had an allergic reaction to that medicine, so was not able to stay on that long. When I reached out, it was a horrible time for me. Pain medicine constantly, it was around the clock, every 6 hours.
Thank you. There's one more question that maybe we could talk about a little bit, which is if you hadn't been able to bank sperm or eggs, how do you think you would have thought about your family building options, like in terms of adoption or sperm donors or egg donors? There are also people who want to know a little bit more about the details of your transplant. So they want to know about how old you are, and they also want to, and how old you were when you went through transplant, and they want to know if you had half match or full match donors. Do you think you could talk a little bit about that? And then we're going to wrap it up, and there will be more questions at the end. But if each of you could speak to some of those things, that'd be great.
So for me, I still feel like if I wasn't able to do egg preservation, the option of having a donor or adoption are still available to me. You know, that's not off of the table for me because extending the family is extending your love. That's still an option. It would be different. However, there's a difference when a child comes from you and it's your bloodline. When I first started it, I believe I was 30 years old, maybe 31. And I am 36 now. So.
When I first started my transplant process was 25. And when I finished, I'm 25. I'm actually 7 months out of transplant currently. And I feel like if I wasn't able to have, a child come from myself, I would definitely have looked into adopting. I feel like where we're getting at here is the biggest point I'm trying to make is when you live with sickle cell, you constantly have these limitations on your life. There's things that you can't do all the time. But when those limitations are taken away from you, I would like every patient to be able to live that full life. So whether that's adopting or whether that's banking, just to be able to spread that love, you being able to do the things that you love with the people that you love. That's the biggest part here.
All right. And so for our last comment that we're going to make, one of the things that has changed in the last 24 months, really, since the NHLBI Cure Sickle Cell guidelines came out about what tests we should be doing before and after transplant for people with sickle cell disease. One of the things that those guidelines now say is that after transplant, you should be regularly assessed for your hormone function and for fertility. And someone asked if either of you have had your fertility reassessed since your transplant. And I want, or if either of you have tried to conceive either spontaneously, natural, without using your banked sperm or eggs, or with using them. Would you each be willing to briefly speak to that?
So my hormone levels, my fertility assessment has been routinely assessed and checked. And post-transplant, I did go through a phase of premenopause and so forth. Those hormone levels directly after transplant have subsided significantly given the time that has happened over the hormone interval assessments. So today, actually, I am about 3 years post, and my menstruation has recently returned while doing hormone replacement therapy. So that's just to give you a little sight. The longer the time from transplant, it is a possibility. Now, I have not tried to have any children since transplant, as in I'm just focusing on myself for right now.
Excellent. Thank you so much.
My hormones levels have not been checked. I guess it's just hasn't been that time yet. I just received my vaccines 3 weeks ago, I believe. But we did order an extra vial just for after transplant. I wanted to see how many live specimens were in the vial when I mail it back to my banking company.
And have you gotten the results yet? Can we ask you that nosy question?
Not yet. I haven't sent it in yet.
We'll be on the edge of our seats. I'd come back next year, right?
Yes.
So we're at about at time. Thank you so much, Ms. Station and Mr. Moore, for sharing your experiences with us. And there will be a question and answer at the end, so we might have some more questions then. But thank you both for your courage and for your honesty with us on a very personal topic today. So thanks for making yourselves available to the community. We really appreciate it.
Thank you, Dr. Pecker, Charlena, as well as Marquise. It was a great presentation and a lot of information pertaining to fertility after transplant. And also, as Marquise said, a special shout out to Be the Match. Our next topic would deal with pain experience of patients with sickle cell disease after bone marrow transplant. Dr. Deepika Dabari is a pediatric hematologist oncologist at the Children's National Hospital and the professor of pediatrics at the George Washington University in Washington, D.C. She studies complications of sickle cell disease with emphasis on pain and has been conducting clinical and translational studies directed towards better understanding of mechanisms of sickle cell pain and its management. Are Takare Yorare is an aspiring physician currently enrolled in the Masters of Public Health program at Emory University Rollins School of Public Health. He received a stem cell transplant at Children's National Medical Center in 2018. Good morning to each of you.
Good morning, Reginald. Thank you for the introduction. We can get started with the slides. So how we have planned this session is I'm going to give some information about pain and what are the factors that may be associated with pain. And after that, we'll talk about Aray's experience with transplant and related to pain related to sickle cell disease. So pain, as everyone knows in this audience, is the most common complication of sickle cell disease. And there are multiple things that happen when a person experiences pain. So there's morbidity, patients get admitted in the hospital. It is associated with poor quality of life. And as we heard in the earlier session, it can really impact what a person can do when they are having pain. Next slide, please. So pain starts very early, and many of our individuals who are listening in today, they may remember or they may have seen that pain starts very early as 6 months of age, as you can see in this picture on the left side, where the baby's hand is swollen and he's experiencing acute pain in that area. As the patients get older, although they still come to the hospital for management of acute pain, we know when we see our patients for severe episodes of pain, it's just the tip of the iceberg. Many of our patients may not come to the emergency department or hospital, but they continue to experience pain as shown here. Next slide, please. So other thing I'm hoping that to also educate audience a little bit, because those are important factors when we talk about pain before transplant and after transplant. So chronic pain is a major problem for sickle cell disease. And the actual definition of chronic pain is if someone is having pain more than 50% of the days in past 3 to 6 months, they are called chronic pain. And the chronic pain pathways, like why someone experiences chronic pain, are very different than when someone experiences acute pain. Next slide, please. You can keep going. So this slide shows some of the reasons why someone may have acute pain and on the background of chronic pain. So someone on the left side, as you see the X-ray of the hip joint, someone may have the avascular necrosis of hip, and that can cause chronic pain. Sometimes they may have gallstone as shown in the ultrasound up there, or the leg ulcer on the picture on the right side. Or sometimes we have this pain, which really is very difficult to explain. We have done the hip imaging, we have done the other tests and things like that, but cannot really pinpoint what exactly is causing pain. And this kind of pain, the image of the person is shown here, is generally multifocal. So there are many sites that have pain, and it's constant, it's impacting them, patients, more than 50% of the days. Next slide, please. So what happens after a person gets bone marrow transplant? It's very clear that, and as you heard earlier, most individuals, if the transplant is successful, their pain goes away. They don't have pain, and if they were taking opioid for controlling their pain or other pain medication, the use of pain medications go down. Next slide, please. But what we have seen in our experience, there is a small group of individuals who may have gone through a successful transplant, but they continue to experience pain. And the pain sometimes is so severe that they continue to need the pain medications, including stronger ones such as opioid, after they have been cured of their sickle cell disease. Next slide, please. So we wanted to see what are the factors that may make a person susceptible to have pain after successful transplant. So this data is from that I'm going to share with you is from NIH, and Dr. Fitzhugh, who's on the panel list here, came from the patients who were treated at NIH and they were successfully cured. So we looked at what are their lab factors, how is their hemoglobin, what are different things in their labs that may be different and can help us identify patients who may be at higher risk for continuing to have pain after successful transplant. These patients also reported what we call as PROMIS measures. So PROMIS measures are patient-reported outcomes. So patients are they will tell us how's their pain intensity, what's the impact of their pain, what is the anxiety level, how's their sleep, and different things that you see on slide. So these were reported by patients, and they are called PROMIS measures because they are patient-reported. Next slide, please. So what we saw that, patients who were successfully transplanted, pain admission, as you can see highlighted here, improved significantly. So pre-transplant, if they were having, range of admission were 0 to 24, after transplant, and this is cumulative data, not just one person. And after transplant, they reduced from 0 to 3 per year. So this was significant reduction. Opioid use at the second highlighted point below, you can see that also went down. So short-acting opioids such as oxycodone, that use had improved significantly, and so was the long-acting like MS-Contin. That use had gone down significantly, meaning the pain levels had really improved. Next slide, please. But as you can see here, there was a group of individuals who, this is 1 year after their successful transplant, but there were few patients who continued to experience pain, and pain was so severe that they needed opioid to treat their pain. Next slide, please. So we wanted to see what are the risk factors and who are those individuals who continue to have pain, and what were their factors before the transplant that may have made them susceptible for pain and opioid use after the transplant. Next slide, please. So what we saw, the definition I gave you chronic pain earlier, there's scientific way of defining chronic pain, but we are not going to go into that. But as you can see here, the red circles show individuals who had chronic pain. They were at higher risk for continue to experience pain after successful transplant, and also opioid use. And patients on the left box that is not highlighted, patients who had just the acute pain, they were totally cured and they had no pain. Next slide. So we wanted to see, was there something different in their labs prior to transplant that may help us identify these individuals? So as you can see here, there were really no differences. So labs prior to transplant, there were no differences when we looked at the patients who had no pain and opioid use after transplant, or pain and opioid use after transplant. So there were no differences between these two groups. Next slide, please. If you can click one more. keep doing. Thank you. Keep clicking. So then we wanted to see what are the other. So we saw the labs were not different prior to transplant. So were there certain differences between patients who continue to have pain and patients who did not have pain? So here are highlighted some of those in the red script on, as you see on the right side. So patients who were older, they were at higher risk to have pain. Female gender was more common in our group. They had more pain admissions prior to transplant, more opioid use, more comorbidities, and also higher pain. So really, if you think about this, they have much higher burden of pain prior to transplant going into transplant. Next slide, please. So we also, as I mentioned, we also had asked about some of the psychological factor as promise measures, so as reported by the patients. So here you can see patients who had higher scores, they were more likely to have anxiety, depression, more fatigue, more sleep disturbances, and pain, higher impact of pain on their daily activity. These were the individuals who were at higher risk to continue to have pain and opioid use after the transplant. Next slide, please. So what can we take out from this information? So we saw that factors, those were associated with continued pain and opioid use after transplant, these were such. Pre-transplant pain experience. So if person has higher burden of pain prior to transplant, they are at higher risk. If an individual had chronic pain, they were at higher risk for having this problem. Older age, higher doses of opioid. So some, especially like long-acting opioid, they were at higher risk for continued pain, and also psychological profile. So if a person had more like anxiety, depression, or some of these other factors listed here, they were at higher risk for continued pain. Next slide, please. So why does that happen? And it's a complicated slide, but I want to inform you why this may be happening. So we know if someone has chronic pain or higher burden of pain, so you experience pain, but in long run, it can impact our brain, the pathways in our brain that help us feel pain. So there are certain changes in the brain that happens, and it has happened over time. So from young age to as you become teenager or adult, the pain is constantly happening, and it has impact on the brain, and that can change the pathways that may lead to persistent pain. The important thing is that it takes many years for a person to reach to this state, and it also may take longer time for them to come back where they may have started. And this phenomenon in science is called neuroplasticity, just like how the changes in the brain occur, and this process is neuroplasticity. So that we believe is very important, how a person is going to respond after successful transplant as it relates to pain. Next slide, please. So what can we do to improve pain outcomes? Because obviously when our patients go through transplant, we want them to feel better, and hopefully pain also goes away. So what can we do prior to transplant? And these are some of the strategies we hope everyone can do that. So first is better control of sickle cell disease, and such as disease modifying therapy. So the sickle cell disease is in control, and really the neuroplastic changes I showed you, hopefully that can prevent from happening. So the goal would be to reduce pain burden prior to transplant by multiple things. So it could be drug, it could be physical therapy, it could be psychology, counseling, and things like that. Opioids, although they are our friends, they also cause damage to brain and certain other organs. So it's important to minimize the use of opioid if possible. And as I mentioned, management of psychological comorbidities with counseling, medication, and other things is very important. Next slide, please. So here we are going to bring Array back. And Array, thank you so much for sharing your experience today with the audience, and hopefully, you can. So do you want to start with your experience first?
Sure. Hi, everyone. As was mentioned, my name is Array, and I am currently a Master of Public Health candidate at Emory University with a concentration in epidemiology. And I received my stem cell transplant at Children's National in 2018. as part of their SUN trial, which is aimed at looking at the efficacy of transplant using a non-myeloablative approach. And Dr. Dvari asked me to join her in this presentation just to share my experience post-transplant. And I can honestly say that I have not had a single episode of sickle cell disease related pain in the 4 years since my transplant. And this is really a stark contrast to my pain experience pre-transplant because I had type SS disease. So as a child, I was perpetually ill and frequently hospitalized. I would say that on average, I had about 2 to 3 hospitalizations a year due to severe acute pain crisis throughout my childhood and adolescence. And it wasn't until I moved to the US from Cameroon and I was exposed to hydroxyurea that my pain experience stabilized. But even with hydroxyurea, I still found myself in the emergency department a few times a year. And I still experience extended hospitalizations due to pain at least once every 2 years. And particularly when I was in college, I found that the stress of the environment really exacerbated my pain experience despite being on hydroxyurea. And I remember in my very first semester when I was at the University of Maryland, I was barely 1 month in when I had one of the worst pain crises that I had ever experienced in my life. And my resident assistant at my dorm actually had to call the ambulance to take me to the hospital. And I subsequently missed about a month of classes. And unfortunately, this would not be the last time that would happen while I was at school. So that's really the primary reason why I like to join these types of meetings and just advocate for transplant. Because for me, transplant has had the single greatest impact on my quality of life as an adult. As Marquise mentioned earlier, the freedom and the liberation that you get after transplant is truly a joyous experience. I can, get up in the morning, go out to the gym, exercise, go for a run, all these things that I couldn't really do before transplant. And I can do all this without like having the fear of having a pain crisis and having to go to the hospital. I can focus on my education and not have to worry about missing classes and all the like. So really, just to highlight the point, I haven't had any pain since my transplant, and it has really been a great experience.
That's great. Eric, can I ask you, in our presentation, I mentioned some of the risk factors, and so I wanted to ask you, prior to transplant, you mentioned you were getting admitted in the hospital, but would you think you had chronic pain, meaning did you have pain more than 50% of the days and higher pain ratings?
I don't think that I had chronic pain particularly. I mean, I feel like a lot of my pain was acute. Like when I would have a pain crisis, it would be extremely intense pain. But when I wasn't having crisis, I wasn't constantly in pain. I was relatively free of pain for most of the days. It was only when I had, a flare up that I would experience very heightened pain.
Mm-hmm. And were there pain medications that were you using, or any other medications prior to transplant?
Besides hydroxyurea, I was prescribed oxycodone, which I took as needed. And so when I was having pain, I would probably take about, I want to say 5 milligrams, every 4 hours of oxycodone. But when I wasn't having pain, I wasn't taking oxy. Besides that, I would maybe take Tylenol if I didn't feel like my pain was bad enough to warrant an oxycodone.
That's great. We are so happy, Eric, that you're feeling so much better and doing well, and pursuing your dream to become a doctor. So looking forward to all those good things.
Thank you very much.
We can see if there are any questions. I don't see any question. So there's a question about saying, what about the case of a 9-year-old on hydroxyurea who's very compliant and still experiences pain? So I can talk about that. So I think pain is a very complex experience. So it's, So I think it's important, and one thing that may fit for one person may not be the best option for other person. So there may be other things that can be, and I cannot speak for this particular child, but I can tell you, we do have some of the individuals who may have very high burden of pain despite being on hydroxyurea or not. We are not able to explain why this child may be having pain. And many of these individuals actually, how to deal with pain has helped quite a bit, meaning like, so especially working with psychology quite a bit. And at our institution, we are able to also use some of the non-pharmacologic measures. So making sure the person sleeps well, how is their sleep hygiene? Can they use acupuncture or acupressure and things like that? So many of our patients have responded very well. And I think this age is really important, young age. And I actually am very proud of one of our patients whom I saw yesterday. Last year, this child missed, she's now 14 years old. Last year, this child missed about 6 months of school. She could not go to school. And I just saw her yesterday with acupuncture and just like, some of our working with our psychology team, this child has missed only like 5 days from, this year in 2022. So that is remarkable, but I think it is important to work with psychology team or your medical team to see what may be the other factors. Does this have does this person have like gallstone? Where is the pain, and what may be the other factors that may be contributing to pain?
Yeah, and great job, Topeka. Can you hear me?
Yes, thank you.
So there clearly are sickle cell disease factors that may contribute to the pain. Dr. Dabari has already mentioned one. What's actually fairly common in children, specifically, and also in adults, is the presence of asthma. About 1 in 5 children to 1 in 4 children have asthma. And the literature is actually fairly well documented that children with asthma have a higher rate of acute chest syndrome and have a higher rate of pain. This has become so commonly recognized that many programs, sickle cell disease programs across the country, particularly in pediatrics, have developed a joint pulmonary sickle cell disease clinic to abate or to decrease the rate of vaso-occlusive pain. So we would be remiss if we didn't at least acknowledge that a common second comorbidity, asthma is a second disease, occurs frequently in individuals with sickle cell disease, and uncontrolled or undiagnosed asthma is in fact associated with an increased rate of pain and particularly acute chest syndrome. So that's number one. Number two is that stress. There's no question at all that individuals who are at increased risk for stress, be it recent divorce of the parents, be it poverty, which in and of itself is associated with stress, will have an increased rate of pain. Recently, there's an article that described 2 young ladies who developed chronic pain syndrome after they were sexually abused. And within months after that abuse, both of them came to the hospital anywhere between 15 and 20 times a year, when before they were only averaging 2 to 3 times a year. So clearly the stress plays a role. For our older adolescents and adults, depression is a major precipitator of pain. And so as we continue to understand more about the disease, there are still medical reasons why individuals with sickle cell disease may be classified as having chronic pain or the like. And I'm always reminded of the fact that individuals with sickle cell disease are just like any other individuals, and they can be susceptible to the level of pain that others have for non-sickle cell disease reasons. For instance, there's a young man that I talk about constantly who had chronic back pain. And the reason he had chronic back pain was because he was playing PlayStation every day. And as a mother said, quote unquote, every waking hour of the day. And so anybody, whether they have sickle cell disease or not, who's in a hunched over position with bad posture, that's sitting in front of a television for 16 hours a day, is going to have chronic low back pain. And so we have to help our families describe the pain that occurs, and so that we can actually distinguish the pain from other sickle cell pain from other pains. And the last point I want to make clear is that it's quite clear when you listen to our young ladies who have started their menstrual cycle. Maybe about a quarter to 30% of our young ladies will have vaso-occlusive pain associated with their menstrual cycle. And we have several young ladies that we've put on birth control to stop their menstrual cycle. And this in turn has stopped their acute vaso-occlusive pain. So there's a range of reasons, and it really takes a open discussion between the provider and the patient and the family to identify these triggers so that we can prevent the pain and not subject them to therapy that may actually cause more harm than good.
Yeah, those are very important points, Michael. Thank you. I agree completely. Ari, there's a question for you. What was your experience like in emergency room?
I would say I had a pretty normal experience in the emergency room. I mean, a lot of times when I went to the emergency room, I was like in excruciating pain. So I was often triaged to the top of the list. I mean, there were a few times where I experienced long wait times, but I feel like that's pretty common in the ER. But beyond that, I feel like most times that I went to the ER, I was triaged to the top of the list and seen fairly quickly compared to most other patients.
Thank you. And I think there may be some differences, and I'm not able to clearly comment on that, but pediatric, and mostly it was pediatric emergency department array that you went to, or that.
Yeah.
So there may be some differences, but it probably would be helpful to hear from adult patients who may have gone through the adult ER.
Yeah, I mean, it also helped that a lot of times I just went straight to Children's National. And so a lot of the providers there already knew me. So when they heard that I was in the ER, I think that kind of facilitated the process even more.
Yes, okay. There's a question asking for about this child with pain. How do you differentiate between acute and chronic in such cases? So there are ways of classifying the acute and chronic pain. So acute pain, as the name suggests, you get the acute episode of pain and you get better. And most of the time you are pain-free between 2 episodes of pain. But once a person develops chronic pain, so the big umbrella definition, if someone is having pain more than 50% of the days and their pain scores are about 5 or 6 or more in past 3 to 6 months, that is the definition. But then person has to work with their physician to identify what kind of chronic pain this may be. There's a question, I think for this could be general audience, that for those who have gone through the treatment, do you feel, and Ari, you can respond to that as well, do you feel it would have been beneficial for you to have transplant earlier in life, such as preschool age, knowing now what life is like before and after?
I mean, strictly speaking, in terms of pain experience, yes, I would rather have gone through transplant early in life because obviously it would have saved me a lot of agony in childhood. But I don't think I would appreciate the value of the transplant as much if I went through it earlier in life, because I guess what I'm trying to say is that my experiences as a child kind of shaped me into who I am today. And so I think those experiences, although painful, were valuable for me into making who I am. So I think I would rather have it done just strictly for the pain, but otherwise than that, I would say I'm grateful that I got to have it done at all.
Thank you so much, Ari. So I think our session is done, but there's a question and answer session. So Kristen, if you want to take it from here. Oh, Stacy's session. Okay.
Thank you, Dr. Dabari, and thank you, Ari, as well. A very, very good presentation. Now we're going to move to the next session, and this is going to be facilitated by Dr. Stacey Martin, and this is called Coping with Sickle Cell Disease, Skills to Strengthen Mental Health. Dr. Stacey Martin is a senior associate scientist in the pediatric oncology branch of the National Cancer Institute and the clinical and training director of the Health Psychology and Neural Behavior Research Program. She's a clinical psychologist with specialized expertise in acceptance and commitment therapy for people with medical conditions. She conducts research with pediatric and adult medical populations, including sickle cell disease, cancer, and NF1, primarily focused on coping with pain and cognitive and quality of life outcomes. In addition, she co-chairs the Pediatric Oncology Branch's diversity working groups aimed at addressing diversity-related issues in research. Wami Bakare is a stem cell transplant recipient and the curator of Sickle Cell Prodigy. As an advocacy trailblazer, she is a patient ambassador for All Stripes and Health Union, and she sits on the Gene Therapy Advisory Board for Vertex Pharmaceuticals and Beam Therapeutics. Fueled by purpose and the pursuit of social inclusion, her advocacy efforts focus on erasing the stigma of sickle cell disease through proactive and reactive engagement with the medium. Good morning to both of you all.
Good morning, and thank you so much for having us. I'm going to speak during the first part of this session, and then Ms. Makare will speak afterwards about her personal journey. So you can go ahead and advance the slides, Kristen. So I'll talk about mental health challenges in sickle cell disease and kind of the areas where people with chronic health conditions get stuck. And then I'm going to talk about this model that we use at the National Cancer Institute and with NHLBI at the NIH, which is acceptance and commitment therapy. And then we'll hear from Ms. Bakare. Next slide. So depression is really fairly common in people with sickle cell. The rates vary depending on what research study you look at, but the average is about 35 to 36%. Whereas in children with sickle cell, you see depression in about 4 to 46%. As Dr. Daban and Darbury both mentioned, there's such a relationship between depression and physical well-being and other aspects of mental health and quality of life. All of these things are connected. We also know that when someone with sickle cell goes into the hospital, such as for a pain crisis, if they have depression, that puts them at risk for staying at the hospital longer. And we also know from research that how people respond to pain impacts how severe their depression is. Next slide. About a third to a half of people with sickle cell report anxiety. It's related to fatigue and depression in sickle cell. And there was one study that found that people with sickle cell who were prescribed higher doses of morphine had lower quality of life and higher anxiety compared to those with lower doses. Now, that doesn't mean that the morphine caused the higher anxiety, but in general, it's associated with more of the worst quality of life and higher anxiety. Next slide. And in our culture, there is this sense that if we have pain or sadness or anxiety, it's bad. We have to get rid of it, right? If you go into the self-help section of any bookstore, these are the kinds of titles you're going to see. Get rid of depression, help your child become happy and worry-free. And this model that we use for mental health says that this might be part of the problem, having this expectation that these things are inherently bad and abnormal. So I'm going to talk about a different approach. Next slide. And there are two areas where we see people with medical conditions get stuck, and that leads to mental health difficulties. The first is inflexibility. The second is avoidance, and I'll talk about each of those. So next slide. What I mean by inflexibility is holding on to thoughts really tightly. So when you have a thought, you take it as absolutely true and you don't look beyond that to see if there are other possibilities. So sometimes people with sickle cell might think, okay, when my pain gets to a 6 or a 7 out of 10, I have to take a pain pill. And sometimes that may be the best response, but sometimes it may not. Right? Or I have to find a new medication or see a new doctor that's going to help me. Or even just on a daily basis, I have to go to work today or I have to stay home today. And where there's no room for any flexibility in that, that's when it becomes problematic. And being inflexible in terms of, being open to new approaches and ideas. And then having this sense that you know what you can and can't do. And sometimes I see people with sickle cell and other health conditions, if I suggest something, they say, oh, I know that's not going to work. But that means they're not being open to the possibility that it might. And that's associated with more difficulties down the road. And then avoidance. This really nice quote here, avoidance is the best short-term strategy to escape conflict and the best long-term strategy to ensure suffering. But what we see in people with chronic health conditions is that they tend to avoid things like their usual activities. They avoid relationships and connecting with people that they care about or meeting new people. They avoid opportunities that they would otherwise jump on, and they avoid things that they are normally really interested in or things that they really care about. So what do these things have in common? Well, both inflexibility and avoidance are attempts to control our thoughts and feelings, right? If I avoid this, then I won't feel anxious or I won't have pain, right? But doing all of this avoidance and being so rigid consumes a lot of our time and a lot of our energy. And that's time and energy that we could be using to pursue what we most care about in our lives. So another way of looking at this is psychological flexibility. And that's defined as our ability to adapt to life stressors, both external stressors, like what happens in your workday, for example, and internal stressors like pain. Now, being psychologically flexible is more strongly associated with a decrease in pain-related disability than pain itself. Right? Pain, how frequently you experience pain and how severe your pain is. So ACT, acceptance and commitment therapy, is a model of psychological flexibility. So again, this is the approach that my clinical team of psychologists at the NIH uses when we work with medical patients. And it's pronounced ACT as a word rather than ACT. And there's a lot of research support showing that it helps people with all kinds of things like depression, anxiety, pain, and trauma, and others. So a few components of ACT. One of them is mindfulness, which is being in the present moment without judgment, right? So much of our time we spend in the past rehashing things that happened yesterday or a year ago or 10 years ago, right? Or in the future, thinking about, oh no, what's going to happen tomorrow? What's my pain going to be like tomorrow? Am I going to be anxious when I have to do this or that? So it really is focusing in on on our present moment, right? What's happening in the here and now. Next. A couple different ways that we practice mindfulness are things like mindful breathing, mindful movement. And all of these things are things that you can look up on the internet, and you will find a lot of information on mindful breathing, just learning to breathe while focusing on the breath and nothing else. Mindful movement, so things like taking a walk mindfully or doing something like yoga or Tai Chi. And then other mindful activities, just going through your daily routine, listening to music mindfully, being really in the present moment and focusing on it, eating mindfully, playing music or whatever hobbies or things that we enjoy, doing it fully connected in the moment. And of course, I think our cell phones are the things that pull us out of being mindful the most. So I wanted to just raise that as a comment there. Next. But why? Why should we be mindful? So when we are not being mindful, we're kind of going through life on autopilot. We're not really focusing on the moment. And that means that we make choices based on just habit or an impulse rather than what's important to us, right? So I'm not going to go to my friend's birthday dinner tonight because I might get anxious or I might start having pain. Or, well, I have this exam tomorrow or a big presentation at work, but I'm in pain, so I've got to take my pain pill. And that might interfere with you being able to really be present in those activities. We know that mindfulness helps with things like depression and pain coping and probably anxiety. There's a little bit less research in that area. And it's also really helpful to learn to practice mindfulness when things aren't too bad, right? It's really hard to learn a new skill when you're stressed out. So when you take some time when you're not really stressed out and practice mindfulness, you can kind of build up that mindfulness muscle. It's a skill that we have to practice. Next. The second component of ACT I'm going to talk briefly about is acceptance. A lot of people, when they hear acceptance, they think, oh, that means giving up or just being resigned to your fate. And that's actually not what we mean at all. Next. What we mean is, and you can cycle through here, thank you. This great illustration here, you can't get rid of your fears, but you can learn to live with them. You can have tea with your fears and anxiety. You can change your relationship with them, right? Or change your relationship with your pain or your sickle cell. And it can be really hard. And that's one of the things that we work on a lot with the people that we see. And acceptance is, importantly, being willing to experience the pain, the mental or physical pain, if it means it's moving you closer to something you care about. So being willing to study while you have some pain or go to that birthday dinner, even though you might get anxious, being willing to experience those difficult thoughts and feelings in the service of something you care about. Next. And then values is a really important piece of this model because people with mental health conditions can lose sight of their values. They're so focused on controlling their pain and avoiding anything that might cause pain or anxiety or sadness that their world kind of shrinks. And all of these really important things out here, they lose sight of because they're only focusing on trying to control their thoughts and feelings and physical sensations. Whereas research suggests that when we engage in values-based actions, doing things that connects us with what we care about, that can actually help decrease depression and a lot of other problems. Next. So what do we do when we identify our values? Well, we come up with goals that relates to those values. So maybe the goals can be around taking medication, nutrition, exercise, spending time with people that we care about. Next. And you can go ahead, there you go. And so we work with people to really plan those things out. Let's just not say that spending time with loved ones is important to you. Let's plan out, when are you going to connect with someone you care about this week? Where will you do it? For how long will you do it? Let's make a commitment that that's something that you want to do. And then notice how you feel, not just in the moment when you're doing it, but also when it's done. Do you feel like, wow, okay, that was really good for me. I really was able to connect with someone that I care about or something that I care about. Next. And I want to wind down by mentioning some resources that I encourage you to look into. These are some books that I find really helpful. They're written in a very clear way that you can kind of really hopefully relate to. But they're all about different aspects of this ACT model and or mindfulness. And the Full Catastrophe Living book is actually talks a lot about using mindfulness for pain. A couple of good ACT websites. And then I recommend these apps as well to people, ACT Coach and Insight Timer. Those can be really useful. And if this is, something that you're interested in or you think you might want to hear more about, I really encourage you to go and look through these resources and see if it's something that might be helpful for you. And I am going to end there, and I'm going to turn it over now to Wumi Bakare.
Hi, everyone. Morning. So today I'm just kind of going to be talking through my experiences as a clinical trial recipient and how I've been able to manage my mental health. So first and foremost, I think when you have when you have sickle cell disease, you're primarily focused on your physical health and not necessarily paying attention to your mental health, because sickle cell is such a chronic, progressive, debilitating illness. And so your mind is just focused on, let me get out of pain, let me start to feel better. But the reality is that your mental health almost starts to take the front seat after a clinical trial, because now you're going through a period of, I know my life with sickle cell disease, and now I'm adjusting to a new life without sickle cell disease. And so a lot of patients that I've kind of spoken with within the patient community, one of the things that we all deal with and have in common is what we call survivor's guilt, which is when you work in the advocacy space, or you have been a sickle cell patient all your life, then you participate in a curative therapy, and now, even though you're well, you still have friends and maybe family that are still dealing with sickle cell disease. And it can be, you almost feel like, why did I make it through and get this chance, and they didn't. So when you're kind of going through the rows of survivor's guilt, I think it affects different people individually, but more importantly, when it comes to mental health, you kind of have to get your mind in that sense of, even though I made it, how can I turn my pain into purpose? And I think the beauty in advocacy is that even in, sitting on a panel like this and having a conversation with you guys, I'm able to feel like I'm making significant contributions to the community. And that's how I'm choosing to channel the survivor's guilt and deal with it in a more proactive, mindful, psychologically flexible process. And then another thing that we all struggle with as well is an identity crisis. And that is just the analogy I always use to explain that to people is, imagine if you've been married for 32 years. In my case, I had my transplant at 32. I'm not 35, so I'm 3 years out. If you've been married for 32 years and your last name changed, even when your husband passes, if people refer to you by your maiden name, you're not instinctively going to respond, because you've had the identity of a wife with this last name for a long period of time. So I always use that analogy because it's kind of the relationship with sickle cell disease is, this is a genetic condition that you are born with. And after a while, you just adopt the persona of like, sickle cell is me. And so when you now go through a clinical trial, you're in that kind of shock phase where you're like, well, who am I outside of sickle cell? What are the things that bring me joy? What are the things that bring me fulfillment? What are my real basic values outside of this disease? And for a lot of people, I think that identity crisis, it takes the bulk of the mental health work that you have to do. I'm honored in a position where, like, because I had my curative therapy done at the NIH, I do have resources, mental health resources. And Dr. Martin here has worked very closely with my therapist, Marianne Tamula, who I want to shout out today because of the brilliant work we've been able to do within the past 3 years of really having me change and shift my mindset from, like Dr. Martin shared, she said, sometimes we're kind of stuck in a rut of sickle cell is me, and I can't see my life outside of pain, not fully realizing that, no, it's more about kind of being conscious of and observing your thoughts. So what I've practiced in my day-to-day now is, sometimes I will be in that mind frame of, I woke up this morning, my body feels like it's in pain, even though I know I have gone through a transplant. And then it starts to kind of shape how my day is going to pan out. But now I'm in a space where I'm in pain. I do what I need to do. I do my breathing exercises, which gets me to be more present with my body. And then I decide, all right, how can I arrange my day where I'm still productive, even though I'm dealing with something that will be more cumbersome, which is pain. And then what I do in that case is I kind of rearrange the goals of what I plan to achieve and just do it from the bedside. I think one of the things that we get, a lot of patients get stuck in, is feeling like, this is me, and I can't see myself outside of this. And sometimes you just have to shift your perspective. I'll share a personal example. So for me, for example, I work in public relations and media. And so a lot of my life, sickle cell has kind of factored into the kind of jobs that I can take because, I started as an entertainment publicist, which requires traveling and being on tour with artists. And then I started to quickly realize that sickle cell just didn't make space for the kind of lifestyle that I was leading. And then I decided, all right, let me take a step back and kind of reevaluate and figure out a way to work with my disease, but also to do things that bring me fulfillment and joy and happiness. And one of the things that Marianne taught me that has completely shifted how I think is, imagine if life is a race and everyone is on the track field. And even though at certain points in time, my health took center stage, it almost felt like I was stagnant and I hit pause in terms of like marriage and children and getting a house and getting a promotion, all of the things in life that like we're supposed to, as women and men, check off and say, I've achieved. My health kind of became the quintessential part of my life and everything else kind of fell to the back burner. And then she kind of changed my mindset and said, if you think about it, like if we're all in the track field and people are running, you're sitting in the bleachers, but what you're doing is you're strategizing. You're watching where people are making mistakes. You're seeing them on the track field fall. And by observing, you won't be you'd learn from their mistakes and you won't be in a position so that when you do hit that track, you kind of already know how to best navigate it because you've taken this time for pause. And pause can represent different things for different people. Pause for me represents either taking some time to practice self-care so that I'm well equipped to handle whatever life throws my way. And of course, in the analogy of like a track field is while I'm sitting in the bleachers, I'm strategizing and planning and observing my peers, but that doesn't necessarily mean the work stops. It just means I'm preparing so that I'm in a better position to win the race when I do get on the track. And I think for a lot of people who have been through a clinical trial, I will always say this. Yes, your physical health is significantly impacted by your disease, but so is your mental health. When we go through bouts of a pain crisis and we're on admission, you have periods where you just feel emotionally low, and then you start to isolate yourself from everyone because you don't necessarily want to be seen as a burden. But the reality is that I think we have different people in our lives that are there to either motivate us or to help us kind of get out of that like mental state rut. And for clinical trial recipients, I will say, if the recovery is 60% physical, it's also 40% mental, because you really have to psych yourself out and tell your body that like, I no longer have sickle cell. So what were my triggers before? They might be my trigger now, but because I know I don't have enough sickled red blood cells to cause a crisis, you then have to do the mental hard work of trying to unlearn certain habits that you had in the past. And for me, I think in making sure that my mental health is in a really good place, I have turned to advocacy. And what advocacy has brought me is the opportunity to form a sickle cell tribe, to meet people who are just like me in the patient community, whether they're on the other side and navigating a like life after a transplant, or whether they're on the other side, which is still dealing with sickle cell disease. I think finding my tribe and turning my pain into purpose has put me in a position now where I feel like I'm creating impact. And I remember the very first day I had my first therapy session, the first question she asked me was like, what are your values? What is important to you? And in determining those things, everything I'm doing now is kind of getting me to the end goal, which is I know my legacy when I live this world. It might not necessarily impact me or this generation, but the younger generation of patients that are growing up will have us as kind of their foundation. It's kind of like in the Black community, how we say we're riding on the backs of the ancestors. My hope and goal is that within the sickle cell space, in all of the advocacy work, that this will be kind of a stepping point for all the generations of children to be born who are going to navigate this space. So that's just a short summary. I tried to be as succinct as possible of kind of my patient experience, but yes, feel free to ask me and Dr. Martin questions.
There is one question that I see, Wumi. What kind of curative therapy did you have and when? I think you said it was about 3 years ago, but what kind, can you talk about the kind of transplant you had?
Yes, so I had a allogeneic stem cell transplant. My brother was my donor, and I had my transplant done in August of 2019.
I just want to say, I really love how you talked about values there. It's something that we find again and again, is that even though with ACT therapy, we don't go in saying, I'm going to get rid of your anxiety, or I'm going to get rid of your pain, because I'll tell you guys something, there is no psychologist who can do that. We just say, I'm going to help you live the best life you can live while you have pain, right? Or anxiety or sadness, whatever it is. And what we find is that when people connect with their values, whether it's through advocacy or whatever else, that they then report, the more I connect with my values, the less I really think about my pain, right? Or the less I feel anxious. It's not what we're trying to do, but it's kind of like a nice side effect of it. So I love how you illustrated that really nicely.
Thank you. I see a message from Kristen. Okay.
Yeah, Kristen, I think we're maybe ready for the next session, or the Q&A or the break.
Thank you, Wumi. Thank you, Dr. Martin. And more importantly, thanks to all of our speakers. Thus far, it's been extremely a great presentation. We're now going to take a 10-minute break. 10 minutes. We are running a little behind, but we did not want to interrupt anyone because all of the information that we're receiving is so informative. So we're going to take a 10-minute break. And if you have any questions, please put them in the chat box, and we'll entertain those questions upon returning. See you all in 10 minutes. Thank you very much. Hello, and everyone, welcome back. We took about a 10 minutes break, and now we're going to start our question and answers with our panelists. We will now begin the question and answers portion, and I will be turning the hosting over very shortly to Dr. Michael DeBond to help facilitate the discussion between the audience and the panelists. For those who do not know Dr. DeBond, let me give a brief introduction. Dr. DeBond is formally trained as a clinical I thought I had that right, Dr. DeBond, epidemiologist, board certified pediatrician, pediatric hematologist, and actively providing medical care for children, adolescents, and young adults with sickle cell disease. He has more than 25 years of experience leading clinical research in sickle cell disease and mentoring medical students, residents, faculty, and fellows, and a very successful career in clinical research. Dr. DeBond, welcome once again, and I'll turn the hosting over to you.
Thank you so much, Reginald, and thank you for our panelists. Particularly, I'm going to give a loud shout out to our families who have joined us, the individuals who have been cured from sickle cell disease and have invited us into their life to give us a frank view of how we can do better as providers and communicate to our families the benefits as well as the risk and expectations after curative therapy. This activity was really all designed to support you all, individuals who have sickle cell disease or their family members, and just could not ask for a better session. And I'm sure there'll be more of these type of sessions where we can actually have your viewpoint. And you are the ones who have been affected by the disease and have lived through the challenges that only you know about and can share with others. So deep, heartfelt thank you from all of us for allowing us to take a peek into your life and for you sharing that with us. We want to get feedback specifically, and let me tell you a little bit of how we got here. There has been, as you know, from the New York Times to CNN to 60 Minutes, this rush to tell people they need to be cured with sickle cell disease. And not the pause in the rush to really understand what are the implications and what's the downside. You know, anytime people talk about the good side of anything, you always have to recognize that there's a risk and there's a downside. And the ability to address the downside in an unbiased way to our families really requires some reflection and input from you all. So we actually wrote a grant that was funded by the NIH that allowed us to systematically assess the impact of having sickle cell disease initially and then being cured. And the importance of this is so that we can actually communicate to our families what the benefits are, i.e. being cured, but also what the side effects are that may change the risk-benefit ratio for an individual family or family unit. And to that end, we've been funded to really focus on the heart, lung, kidney, reproductive issues, as well as the brain eventually in this patient population. So what we'd like to do now is open this up to really get some general questions from the audience as to what we've heard for the last 2 hours or so, and then to have our panelists give us feedback about how they think that this went and how we could do a better job to solicit the input. You may have questions between yourselves. There really should be a community of individuals who have survived transplant and curative therapy, so that you all, because you're in a special club and there's almost no venue for you to share your experiences for us to learn. I mean, we need to hear from you. So let me hit pause here. I think I've given a long enough introduction. Marquise, I'm going to start on you. Start with you first, okay? Share with us your thoughts and any questions that you may have for the general group, or even among those who are panelists who have been cured after treatment with curative therapy.
Well, my thoughts is that this is extremely, I'm extremely grateful that the doctors, you guys take your time just to create a platform such as this. The sickle cell community needs to know there is a cure. I hear all the time, they get misinformation. They don't think they can qualify for the cure. And I'm talking to individuals who have literally no hope for their situation, and there should be. We're the select few. I'm very grateful every day I wake up not to have to go through the extreme pain or those worries in my mind of slowly leaving. But definitely feel like it's extremely important for us to come together and, help the sickle cell community. I know when I had, my disease and I was going through, I didn't know one person who had sickle cell. I thought I was the only one in the world. I had a symposium not too long ago, and my mother had reminded me. She went up and spoke about my life. I told her growing up that I was cursed. I told her, and I believed that, I was cursed out of the public. It was something that the overseer saw in me that he didn't like. And that's why I was being punished. So I know there's families and patients out there that think the same, and there's no need to think that way anymore,
I hear you. Thank you. So let me move over to, can I say Mrs. Bakari? Will that work? Now, how do you pronounce your first name? I'm sorry.
Woomy.
Wooney. Okay, thank you.
Mhm.
So the question from the audience is actually from Dr. Fitzgerald. What was the biggest concern that you had about moving forward to transplant? And have there been any surprises after your transplant? And this could be for anyone, actually.
I would say major concerns prior to transplantations was two things: death being one, or rejection happening. And that's primarily because 8 months prior to my transplant, I lost a dear friend of mine who was an amazing thought leader in the sickle cell space, Jasmine Rivera. She participated in a curative therapy, but caught an infection and didn't survive it. And so at the time, right before my transplant, I was in that hazy, do I go all in, or do I back out? Because she didn't make it and everything went well based on her procedure. So those were two concerns. But the reality is, speaking solely for myself, I was desperate. For me, I had, like Marquis said, I was in a place where I, told God, I said I didn't want to live past 30 with sickle cell. And I found out my brother was my match 7 days to my 30th birthday. So for me, if that wasn't a sign from God, I don't know what is. That, hey, I need you here. There's work to be done on this side. So because I was coming from a place of desperation, I will be completely transparent and say at the forefront of my mind weren't necessarily the risks of, graft versus host or rejection, everything. I just wanted a better quality of life. And I think all patients on this panel can appreciate that. And that resonates with you because sickle cell rids you of so much. It's so unfair and incredibly unpredictable. And so embarking on this transplant journey was with many thought, was with a lot of difficult conversations with my family. I am Nigerian, born and raised, and in the African community, curative therapies is a conversation starter, but at the same time, it's like we also have our cultural beliefs of like, if you were born with it, God made you have it for a reason. Why change that? Those kind of ideas. But the reality is, for me, I'm very gung-ho when I want to do certain things, and I get everyone else to join the bandwagon. I think that's why I'm in communications. I'm very good at pleading my case and getting everyone to see the reasoning behind taking that decision. And because my brother was my match, I think he had seen firsthand my struggles with sickle cell disease. And so it was an honor for him to be my donor. Now, what I will say was the after transplant, the most shocking thing for me was pain. Although I recognize that a transplant is not a magic wand, the reality was I didn't want to be on constant opioids. And so I was looking forward to ridding myself of them. And within my first 2 years, I really struggled. I struggled physically because my body still thought it had sickle cell. I'm still dealing with AVN in my hip and both shoulders. So in kind of getting through that journey, what I always tell people is it's mind and body. That's what a clinical trial is. And until you fully understand that, don't take the knee-jerk decision to go through a clinical trial, because there will be different ebbs and flow of that journey that make you question why you did it in the first place.
Can I interrupt for 1 second? Because I want to get the other panelists in. But you just hit on a point that I think it's important. How should we being the medical community, prepare our families to anticipate that if they had pain coming in, particularly multiple pain episodes, then they're likely to have pain coming out, and it's not the magic wand. You're not going to be relieved immediately. How do we, what is the language or the message that you think that we can use to improve the communication to the families about this point? Because my sense is that that usually is a discussion about the pain. It's not going to go away. So you probably heard it, but again, it seems like you were like, wait a minute, this is still something going on. So how do we better frame the expectations?
I think it's having the conversation of continuity of care. I think the reality is post-transplant, you will still require meds, you will still require hospital visits. So it's just giving people the benchmark of saying, plan to have your recovery to not feel like your full self until 2 years. That's the realistic expectations, because you will still encounter different types of pain. And sometimes with sickle cell, we only see chronic pain, that everything else kind of bubbling in the middle. We can't necessarily pinpoint this is this type of pain I'm dealing with. So it's kind of, I think, when you have communications with patients and families, is preparing them to say, hey, we're going to do this for you, but prepare to not feel like your whole authentic, the best version of yourself that you've ever been until the 24-month mark on whether that's gene therapy or transplant.
That's great. I'm going to move over to Shariana. Did I say that right?
It's Charlena, but you tried. It's
snap.
okay.
Okay, sorry, Charlena. Well, I can blame it on my eyeglasses, and I didn't see the L. Okay.
No worries.
Okay, so thank you again. Let me ask you this question that's been posed to the panel. Dr. Kasim would actually want to know, what were your mental health struggles and readjustment challenges to regular life as a young lady who has now been cured of sickle cell disease?
That's a really loaded question. But I would say that, like we spoke of in the past, that depression is a key factor with having the pain. as well as, when you're doing that. So mentally, you are conditioned to thinking of yourself as a person who has this disease. And so after you've gone through the transplant, you have to mentally change how you view yourself, how you talk to yourself, and how you act with yourself, and how you're thinking and processing your thoughts. All of that plays a really good role into identification mentally into who you are post-transplant. I still work on this today, taking my mindset out of a person who has not such a good quality of life, or a person who has to live so much of in the moment that I'm feeling well right now versus I'm having a continued moment of feeling well. And so I don't have to pile on all of my activities or all of my goals and pressure them on into this one moment. So I hope that answers the question.
It does. It does. And let me ask Dr. Is it Martin Perron? Is that correct?
Yes.
So we've heard now in 2 consecutive years, we had this panel again last year, that really the mental health component has been underestimated in the pre-transplant and post-transplant space. And so it's not actually in our set of guidelines, like you should have a mental health assessment, you should be treated with the following cognitive behavioral therapies prior to transplant, and then continue this strategy post-curative therapy, be it gene therapy or transplant or the like. Is there an opportunity for a proactive approach here in transplant programs where the psychologists can integrate the anticipated challenges of identity, of who am I now? I mean, it's very lovely stated by Charlena, sorry,
Yeah, Shalana.
yes,
Yeah.
Charlena, very eloquently stated. It's like this tug of war. Am I still that person that I was before?
Right, right.
Am I a new person today? How do we help be more proactive in this space?
Yeah. So in our program, we see all of the transplant recipients before their transplant for a neurocognitive assessment, and that includes looking at things like depression and anxiety and quality of life. And then, so some people we kind of flag through that, like, wow, it seems like they may need a little bit of additional support. Sometimes the medical team will come to us and say, hey, this person is coming soon and we think they might benefit from additional support. Or the patient says, hey, is there someone I can work with to support me while I'm there? I do think the point about identity is so important, because we have a lot of people who go through transplant and don't have sickle cell anymore and still feel like, depressed or anxious because they're like, I don't know who I am anymore, right? And so that's the part that that we can talk to them about, like, what are the parts of your identity that are core and that will stay the same? What are the parts that might change? And just walking them through that and letting them know to expect that kind of shift can be really helpful. But yes, I think a proactive approach is definitely the way to go.
Right. Are you aware of any curriculum or guidelines in this space? It just seems like it's an information gap, and every program does this differently. And I hate to say this, but we're learning on the fly, right? We're actually not, okay, we're going to be proactive, but what's best evidence strategy for being proactive? Are you aware of any guidelines that we could learn from so that we can be more on a solid footing of what we should be offering our families?
There are a lot of articles, a lot of research articles that talk about here's our approach and here's our approach, but I have not seen any guidelines where there's an agreed upon curricula that should be kind of used universally. So we have a ways to go.
Well, stay tuned. That's our agenda. We will figure that out. Okay.
Great.
Courtney, you out there? You hear me? We will figure this out.
Sorry, I was going to chime in here a little bit because earlier this year, and I think Dr. Fitzhugh is aware of it, for the Human Genome Research Institute for their gene therapy program, we did put together educational materials regarding mental health. working with like Dr. Marsha Treadwell, who is a kind of one of the lead mental health experts in the sickle cell disease space, of educational materials for patients and their families to kind of guide them through the mental health process. So it's already, I believe it launched September 28th. So I'm happy to share the information in the chat, the link, so people can kind of get more ideas.
Yeah, that's great. Thank you, Wumi. It's very helpful. We're familiar with Dr. Marsha Treadwell's work. Most of the work that we're describing when we're discussing about evidence-based is best practices that have been established as working. Because we all have our own programs that, we have the psychologists as almost a requirement that interviews patients prior, as you just heard, that occurs at the NIH. But we don't know what works when we start to compare what happens at Emory versus DC Children's National Hospital versus Vanderbilt versus University of Washington versus Guy's in St. Thomas in London, whatever the case may be. I want to turn it over to ask Ray Takar. Did I get that right?
Yeah. Yes, you did.
Wow. Okay, that's first. So you were a student and you had to struggle through some of the challenges of having both sickle cell disease and the challenges that we all know about when you start something new, i.e. a new job, school. Do you think that your transition from being that high school student to that first year college student and that added stress of having sickle cell disease, having to explain it or not explain it, the tension of missing class, and what does that look like for you in terms of trying to get your best grades? Do you think that stress or tension actually influenced the severity of your disease?
I would definitely say that it did, because for me personally, there was a marked difference in the frequency of crises that I experienced while I was at college versus when I was in high school. Because I feel like when I was in high school, my disease was pretty well managed with hydroxyurea. But when I got to college, there was definitely added pressures, just trying to figure out how to navigate an environment, because that's also like the first time of me being away from home, from my family. So there was that added stress and then the pressures of school. So I definitely feel like that weighed a little bit on me and increased the frequency of my pain crises, and also the severity, because like I said, I missed months of time from class, not just like isolated incidences, but recurrently.
This is always a tricky question in an interview, but if you had to look back and say, okay, I'm going to go to college, I'm going to go through a high stress window. We have some adolescents and young adults and parents of adolescents or young adults out there. What advice would you give them in terms of trying to decrease this added stressor of being a new student or a person starting a job? Because now you're another new student, right? I mean, you're in another school, yeah. Right? And so what, although you don't have sickle cell disease now, what would you suggest would be reasonable strategies to help families overcome these anticipated barriers?
I think the biggest key would be to be aware of your triggers. So know what situations can potentially put you at a high risk for a crisis. Like for me, I love playing sports, but unfortunately that was one of my triggers. So I feel like when I was in college, I might have been a little overzealous with the freedom that I had in playing sports and being too energetic. And so that put me at higher risk for sickle cell crisis, because I didn't have my parents there with me telling me, oh, you need to scale back, you shouldn't exert yourself as much, this, that, and the other. So being aware of your triggers, and definitely just increasing your water intake just to accommodate for any potential stress that you might encounter, because water is like the best preventative measure, for me at least, in terms of preventing the crisis.
That's great. That's great. And so I want to turn it over to Marquise again and just see if we can get some comments about now that he's been cured of sickle cell disease and he's gone through this tumultuous time pre-curative therapy. you have these you have these adolescents who are struggling with what is their life going to be like 5 years out, 10 years out. What would you say to that 15-year-old who's in high school trying to work through these challenges that you had to work through? What's your recommendation to the parent of the 15-year-old and the 15-year-old?
Well, I would definitely tell them that education is key. The reason why I am here in Cured is because we've done our own research, and I understand having sickle cell life is extremely difficult and unfair, but you shouldn't just throw in the towel just because the game gets hard. I know what I'm saying. Like, you have to push forward. You have to want to be cured and want to do it for more than yourself. Having a better life is, that's a good reward, but you can't give up. I feel like the patients that are reaching out to you and following up to get cured and looking into gene therapy, these are all patients that have not quit. There's two types of patients for sickle cell. You can have those patients who, even though life is hard, we're going to push forward. And then you have those patients that, they don't want to deal with it anymore. It's too much.
Okay.
Myself, when I reached out to the transplant team, just being around my son and my wife, it did occur to me that, my time here might be very short. Just from health-wise, I couldn't do anything. But I thought to myself, if this is the way I'm going to go, I'm definitely going to go out fighting. I'm not just going to lay in bed and just, let whatever happen. I'm going to give it the best shot that I possibly can, because not only me, but my family as well deserves that better life. So I would definitely tell them to hold on. Life gets hard, but push through and take it one day at a time. When you think about the big scope of it, from suffering and pain medicines to being cured, sometimes it seems like an impossible journey. Seems like the longest road ever. But if you take it one day at a time and you keep your mind set, what you want, what you want life to look like after transplant, you'll make it.
Beautiful. Beautifully said. Beautifully said. I have one last question, and then I want to open it up and see to the general panelists and see if they have additional questions. We don't talk about it this way, but in fact, this is the way it is. Curative therapy is now a marketplace. By this, I mean, if you go to, even in the same city, you go to institution A, you get offered one type of curative therapy. You go to institution B, you get offered another type of curative therapy. And oftentimes our families are unaware that there are market forces that may dictate which therapy is being offered. How do you think, as providers, we can be more transparent so that you all, as individuals with the disease, can be informed of all the different treatment options that are actually available and which ones are truly experimental, like less than 100 people in the world have actually undergone those therapies, versus the ones that have been accepted as more traditional therapies? Does that, you all follow what I'm saying? How do we do a better job of educating our families so that they can make the best decision for themselves and not just stumbling into the office of a doctor who says, well, this is how I treat sickle cell disease, and not really giving you the full spectrum of the options that are available? This is for any of the individuals who've been cured for sickle cell disease, with sickle cell disease.
I'd like to chime in on this one, because originally I sought out gene therapy. And throughout my process of getting the gene therapy, the genes weren't able to be extracted from me. And so because I had already gone through the process of transplant and conditioning, at that point where my genes would not release through the machine and through the medications, I had the option to change up the type of transplant that I was getting. So I was originally signed up for the gene therapy, and I end up getting the stem cell transplant. So I think as far as this marketplace question goes, I think a portfolio of there's gene therapy, there's bone marrow transplant, there's stem cell transplant, there's half match, there's full match, there's, this other treatment, a portfolio of all of the information and where a person can go to find all of these things. I like to refer people to clinicaltrials.gov because that is a really good resource to be able to find out all of the different criterias and all of the different institutions that are out there in the US that provides these different types of transplants. So I think giving all of the information and what the effects are, how many people have gone through it, and all of the numbers and education behind all of these different types of therapies and curative therapies is something that should be given to the patients.
Excellent. Any other comment from the panelists around this issue of how do we improve transparency in the curative therapy marketplace?
Yes, I would just like to say, just lay all the cards on the table. Tell the patient and their families what treatments have taken place, how many patients have been cured from X treatment, and just let them make the choice of which one suits them better.
Well stated. All right, so this is kind of open mic moment. Any comments from the panelists in general, questions that they want to address? I see Angelica. Yes, go right ahead.
Thank you so much. First, thank you to the panelists, all of our professional.
We can't hear you.
Who've actually, oh dear. You'll have to go to the next person. I'll come back.
Okay. Lydia, Dr. Pecker, go right ahead.
Hi, thanks again to all our panelists. I just wanted to say to folks who are listening at home that I spend a lot of time in my clinic talking about transplant opportunities with my young adults who are 20 to 30 years old, mostly my patients, and I have a lot of amazing conversations. But one thing I want to share is that there are many barriers to jumping through all the hoops to get to transplant. If you don't know if you want to go through transplant yet, but as you make up your mind, there are a few things you can do to get ready. One of them is make sure your teeth are in the best shape possible. Dental care is a fundamental part of sickle cell disease care. And if your teeth aren't in good shape, you can't go to transplant, and it's probably making your sickle cell worse too. Similar fertility preservation, you can do that well in advance of transplant. So if this is even something you're thinking about, you can start getting your ducks in a row of all the different hoops you have to jump through, because as all these panels can tell you, the time from when they decided it was time to do something different with their disease to when they actually arrived at that day, it can be a long time, and some of these people even had their journeys disrupted by COVID, which obviously there's nothing you can do about that. But helping to develop that list of things that are within your control as you think through this process can be helpful.
That's great. Dr. Dabari.
Yeah, I thank you, Michael. So I want to ask, Marquis or others who have managed their pain. And many times what happens is like very much dependence on opioid, which we know sometimes in long run can cause more problem. What were some of the strategies that you used and helped you wean those doses of opioids?
For myself personally, just being able to go to the park, simple things, go out to eat. Me and my wife will plan something for the day, just go do it. I feel like just having that distraction or being able to plan something for your day, your mind's not really thinking about pain or the pain medicine. I feel like where the misuse comes in with opioids is when a patient is maybe in the house and they have an episode or a trigger occur, then they think, oh, I need pain medicine or I need to get this under control before it, gets out of control. But if you have things to occupy your mind, you can easily get off of them.
Thank you.
Any other comments from the panelists regarding this question?
Yeah, I can add to that quickly. So I think for me, my pain management was more so yoga and physiotherapy. And that's just because for me, I never used to do like physical activities like weightlifting or anything because it would always trigger a flare up. But now on the other side, like I've kind of eased myself into, the early stage beginners yoga and then transition that way. It's also helped me with my AVN because now with physiotherapy, I've been able to strengthen the muscles in kind of my left leg where I'm not putting a lot of weight on the right hip where I have the AVN. So just finding complementary therapies like that, like Epsom salt baths, you know what I mean? And like massages and things like that helped me kind of slowly start tapering off. And then now I'm on Suboxone. So, and that's what I use for chronic pain. And then the realization also that now Tylenol does work for me. It didn't before because my brain had and my body were programmed to only opioids is going to kind of get the pain under control. But like Marquis said, if you distract yourself with like music or journaling or Netflix and things like that, then over time you're slowly able to kind of shift your mindset from a dependency on opioids to things that are not dependent prone.
That's great. That's great. So I see a couple of hands, and then I also have Dr. Shala's question that she tried to ask a few minutes ago. So let me ask that question first, and then we'll go to Sharlana and then Dr. Kasim. Okay. So the question is, I would like to ask what are the reasonable expectations of a curative therapy, hematopoietic stem cell transplant? Like, for example, should we say 2 years? It takes 2 years to feel your baseline self, so that every 3 to 4 months there's not a consistent improvement, but actually you're at that level where you feel as if there's no further improvement from the disease. And how can we set up this expectation with our family so that when they come into curative therapy, we can actually give them a timeline about how to what to expect in terms of getting to a baseline. I think that was the sentiment of her question. So, Sharlana, could you answer that question for us, if you would?
Sure. I feel like this might be a case-by-case basis. I feel like, each individual and their effects from the chemotherapy and the fatigue experience post-transplant is, sometimes it lingers a bit longer than in one patient to the next. I, in particular, was quite fatigued for about 6 months out. And then I kind of felt like an uptick of energy and so forth after that 6-month mark. And then after that year mark, yes, I was becoming more accustomed to having a new level of energy that I hadn't really experienced before, because pre-transplant, I was always fatigued. I was always tired, so afterwards, I would say at that year mark for me is when I kind of felt like, okay, it's now a bit normal to have this type of energy and to become accustomed to it.
That's great. That's a great answer. This is another note for us as investigators that your first response was case by case. We want to turn it from a case by case to, out of 100 patients, out of 200, out of 500 patients, out of 1,000 individuals with sickle cell disease, what is the average time? What's the longest time? What's the shortest time? Because this provides that information that Marquis asked us to provide when we described the different options. Because even with the different timetables, if you will, it may be different based on the type of curative therapy that you received. So we have some work to do. Sherlana, you were going to make another comment because I just put you on the spot for that. Did you want to make your comment now?
Yes, so I think, being active is really important. Having activities to do would help with that energy and so forth. And then just to go back on a topic that you had spoke with prior on, the examples of how the opioids affect you and so forth. And my personal experience was I didn't use opioids on a daily basis. And whenever I would have a crisis is when I would use those opioids, and then I would then wean myself off. So I think with that method, that helped me post-transplant and not being really reliant or needing to use the opioids afterwards.
That's well stated. Thank you. So I'm going to turn this over to Dr. Kasim, and then there's actually a question in the chat box, Dr. Kasim. So this is like me talking to my cousin. We've been working together so closely, so it's hard for me to ask Adetola a question in the public domain without smiling. So let me see if I can get, so Adetola is from Lagos. He's a head of transplants for sickle cell disease here at Vanderbilt and the director of the sickle cell program for the adults. And there's a very specific question, Dr. Kasim, around, let me see if I can find it, options for children in Africa. For those who do not know the demographics, 300,000 children are born with sickle cell disease a year. 70% of that 300,000, so 210,000 or so, are born on the continent of Africa. On the continent of Africa, Nigeria has 50% of all of those births, so 150,000 children. And then within that scope, you can imagine 150,000 children born with hemoglobin S per year. There is many of the parents there have the same hopes and dreams that parents in the United States have. And one of those will be, I have a child with sickle cell disease. I would like for my child to be cured. So Dr. Kasim, you want to at least address what the realities are for curative therapy. And then the topic that's often not described is the boutique approach to curative therapy that has been set up in India that has actually caused far more harm for those individuals who receive those transplants than good.
So, no, thanks, Michael. And, I think the panelists are, it's just fantastic. Everybody has been pretty clear. So to the question of why not in Africa, so Michael is my Nigerian brother. He can actually answer that question. I think he travels to Nigeria more than me currently. He knows the terrain. But the challenges are multiple, chief of which is supportive infrastructure. 2 is the cost of the procedure itself. 3 is how do you manage patients after transplant? All throughout the morning, we've talked about long-term effects, being able to use alternative adjuncts to manage complications after transplant. Ms. Wumi Bakare was very eloquent in talking about things like yoga and alternative therapies. So these are challenges that makes right now transplant difficult, especially in low resource areas in Africa. I think over time, there are going to be strides to try and get this going in probably higher resource areas of Africa. But the other bigger question that's going to come into play is, can the masses afford it? Like most of you know, transplant is expensive, even in the United States. You have to be insured to be able to get it. So these are really the obstacles we face. So hopefully over the next few years, there will be areas in Africa where we can come up with cost-effective strategies to transplant for patients who truly need it. But you even have areas that don't have adequate blood supply. to be able to support patients undergoing transplant. So the challenges are multiple. We just have to slowly work our way through it. Now, is that okay, Michael?
That's perfect. Let's see if there's if that answered the question for the person in the audience. They can send a chat back, and if it didn't. So you go ahead with your original question, Dr. Kassim.
Yes. For the panel, I guess the panel we have here today are so eloquent and may not be totally reflective of the larger sickle cell community, who are also struggling with understanding what options they have for curative therapy. Even we have patients with stroke who are struggling even in school. They have cognitive impairments. So being able to even do that research to make decisions is a challenge. Have you all thought about developing a post-transplant or post-curative therapy support group to help the larger sickle cell community, the warriors, and also because everybody is very active on social media now, and being able to talk one-on-one with these families and hearing from you as a survivor will go a long way in educating them. So that's one. But for Ms. Shalana, if I pronounced it right, her experience is something that is not well described. And I think something that happens rarely, but it does happen, that she was initially scheduled for gene therapy, but her cells was not able to conform to gene therapy, and she had to be switched to the allogeneic transplant. So these are part of the things the consumers need to know. And I find that actually very intriguing that maybe even those who undergo gene therapy, there has to be a backup mechanism for them should in case their cells don't work. I think that's all, Michael.
Great. Thank you, Dr. Kassim. Wunmi, let me hit pause, see if there's any other points to follow up from Dr. Kassim. Otherwise, Wunmi, please, we're getting close to the end here. So please engage us.
Okay. So I was going to say thank you, Dr. Kassim, for the point you made. So for me, what I did is I took it upon myself to do what is called the patient roundtable. And what I've done is, and I can put the link in the chat box, is a YouTube panel with gene therapy recipients, bone marrow, and stem cell, basically giving firsthand accounts of the patient experience from pre-clinical trial to post-clinical trial. We're all at different stages of our recovery. And what that information is going to do for the sickle cell community, both here and internationally, as someone that is international myself, is educate patients on as a first-hand guide, because I think we love our providers and they understand the research and the science, but patients in the community and caregivers want to hear firsthand from people who have been through it, right? And I think even in advocacy, that's why the work is never done, is because we need to put out content as much as possible. I've done that on Essence. I've done that with because the goal is education is key. I think for me, as someone that is from the African continent, I always say Africa is where my heart beats the strongest. And so it's super important that internationally, people need to be better educated on the options. Sometimes I think people don't even know the options. They just assume bone marrow transplant is the only cure and don't really have a full understanding of gene therapy. So my goal, I know in my advocacy work, is to make sure that we're constantly having these conversations. And as far as support groups, Shalana, you and I have been on a different panel before, but I've connected with a number of gene therapy and stem cell and bone marrow recipients, because I think the onus is now on us to make sure that in telling our patient experience that people are, whether it's researchers learning from it and doing better for future patients, or whether it's like private sector companies wanting to start offering clinical trials. I think they need us to be a soundboard so that when patients are making more informed decisions, they're coming from a place of understanding and knowing that when they come out post-clinical trial, there's a support of people that are going to be here for them to guide them through what that unique experience is like.
Thank you. Very well stated. Dr. Martin Perron, you had a comment?
Yeah, I did. I just wanted to say that one of the things that we have worked on in the past at the NIH is to try to get a support group moving for people who are going through the transplant process or considering it, and just logistical problems kept occurring, and then COVID. But right now, recently, we've just started talking about it again and how it would be really great to do something like that remotely or virtually. And I would love to reach out to the panelists here who are the transplant recipients to see if that would be something that you'd want to take part in from time to time again. So yeah, we're still in the planning process, but I'm hoping that that will happen within the next few months.
That sounds great. So we're coming close to the end. I just want to make a comment that we often talk to the individuals who had a successful curative therapy experience. And we really have to keep in mind that in several cases, in many cases, there's an unsuccessful experience. The best of the unsuccessful experience is that you revert back to your original disease. The worst outcome is that you actually die as a result of the curative therapy. And so as we construct these panels, I think the opportunity to hear from those families who have lost a loved one would be important to consider. Obviously, for the adults who can make an informed decision, and as Marquise has said eloquently, hey, I wanted to get on with it. One way or another, I wanted to take that chance. And I think that's the right of every adult in this era. To make that decision. It's an autonomous decision. He's well informed, he's well read, and he's made a decision to undergo experimental therapy that may cure him, but also may cause his life to be shortened. And he understood that trade-off. And so as we begin to talk more openly about those trade-offs, because each one of these treatments that we described have trade-offs, many of which we do not know, then it becomes important for us to rally together, both as providers and patients, individuals affected with the disease, so that we can better understand the nuances of what questions we should be asking in the next 5 years or 10 years. And so for this reason, the panel was created, and this day was created to really listen as opposed to talk. And so we're all very grateful to you all. We're going to be coming back to you because, in fact, just to give this, I'll give a 1-minute infomercial. It turns out that curative therapy for cancer, which includes transplant, has revealed that complications occur in those children and adults who receive curative therapy 5, 10, 15, 20 years later. And this science of what we can expect will happen after you receive chemotherapy to prepare your bone marrow for transplant or gene therapy is evolving. And we don't want to make a decision about what the long-term effects of being cured will be from individuals who don't have sickle cell disease. And right now, that's what we're doing. There's really no formal study in the United States, and for that matter, globally, where we can say to you, if you've had treatment A, here's your risk of premature menopause. Here's your risk of infertility. If you've had treatment B, here's your risk of a malignancy. Here's your risk of lung complications. Here's your risk of kidney complications. And we believe as the field continues to grow, there should be an opportunity to fill in these gaps in knowledge. And so to that end, we're going to set up a registry specifically for families who have had a child or individuals themselves who've been cured of sickle cell disease, so we can track the long-term outcome of this disease. This will be driven by families. So it doesn't matter whether you're in Amsterdam or Rio de Janeiro or Lagos. We hope to be able to collect this data in a systematic way, and we'll be asking your advice of how to roll this out in a way that will allow us to get the data that you are most concerned about. Because in the end, this information is only important if the families who put the information in have control over what questions are critical to ask 5 years from now and 10 years from now. Does that, you follow the logic of what we're going to roll out? We hope to have this up and running in the next 6 months. It has to go through the appropriate research guidelines. We plan for this to be done internationally. And we hope to have as many as 1,000 survivors of sickle cell disease who've been cured of this disease so that we can ask and answer these questions in a systematic way. So stay tuned, and hopefully next year this time, either in the first or second weekend of October, we will be able to provide you the results of at least the first phase of this approach to have a patient-driven or individual-driven registry of survivors of sickle cell disease after curative therapy. All right, I believe we're close to the end. Reginald, you want to take us home?
Actually, before we do that, I do think we have a little bit more time. Hi, this is Kristen. I didn't turn my video on, but there was a request, since we do still have people here in a few more minutes, about in the chat, we would appreciate comments from both the doctors and recipients regarding the buprenorphine use prior to or after transplant. And I want to make sure we see that before we go.
Okay, I missed that. Lydia, Dr. Pecker, did you want to comment?
Sure. We have recently published our experience using buprenorphine for our adults with sickle cell disease at Johns Hopkins. And for a subgroup of people with sickle cell disease, this seems like a very effective way to treat pain and also reduce the need for coming to the hospital a lot. But just like every other new treatment for sickle cell disease, it's something that we think you should be talking about with your doctors and making the decision that's right for you. There are people for whom buprenorphine has been transformative. We've had patients who've gone from 30 acute care visits in a year to 2 or 3, really changed the trajectory of their disease course. But it's not right for everyone. But I think it's emerging as an option. You know, I'm always interested in the parallels between the ways that we talk about buprenorphine actually and the way that we talk about transplant. We hear a lot of the same things from the patients who take the leap, you know, and they take the leap. It takes courage to take the leap to try something different. So I do think if you think that you're on chronic opioid therapy and the doses are going up, or you're coming into the hospital a lot for IV opioids, it's something that's worth talking to your doctor about. We are seeing that it changes things for many of our adults with sickle cell disease, but it's a new treatment and we're still learning about it.
Yeah, if I can chime in, I think it's important to discuss this before transplant. And the reason is because most patients undergo they're introduced to so much medication. It's quite a delicate balance because of drug interaction during transplant. However, post-transplant, managing that becomes a little easier to help patients manage chronic pain, which usually pre-exists before transplant. And one strategy we take is to kind of link them up with a team that manages chronic pain or even addiction medicine, and slowly be able to win them off over time since they're cured, and also address comorbidities that may be contributing to their chronic pain.
Okay, so any last questions that I've missed, Kristen? You can see who actually runs the show here. It's Kristen has done a wonderful job of putting this together. She is an army of one, and she really has done a fantastic job. For those who are unaware, there hopefully will be a transcript available for our colleagues. We work with several of our colleagues in in Brazil, who speak Portuguese. We have colleagues in Amsterdam, who speak Dutch. And then we have our colleagues in the UK who speak the Queen's English, not exactly American English. So I'm not sure how we're going to translate that into a fashion that they will understand, but nevertheless. So Kristen, hats off for a wonderful planned activity, and really thank you for the format. Reginald has a whole long list of folks who should be acknowledged as well, and I'm going to turn it back over to Reginald.
Thank you very much, Dr. Devon. First, we would like to thank the families for their time and their comments. We hope to continue this work with members of the sickle cell disease community and welcome individuals who would like to serve as a part of our advisory committee. Being a part of the advisory committee is critically important as we help to move forward ongoing research. We're also grateful for those individuals who have joined us for our second annual Global Cure for SCD event. And we hope to see you in 2023, as Dr. Devon just mentioned. But before we go, as he indicated, we have a long list of individuals we need to thank. Believe it or not, for the past 3 hours, it has been wonderful, but it has taken a myriad of individuals to put this together. So let me begin by first giving acknowledgments to the Coalesce investigators, Dr. Michael Devon, Dr. Courtney Fitzhugh, Dr. Deborah Freeman, Dr. Lydia Pecker, Dr. Dikebe Dabari, Dr. Ann Hott, Dr. Elizabeth Stanger, Dr. Angelica Chalwa, Dr. Emmanuel Volokis, Dr. Adatola Kassim, and Dr. Rick Jones. Also, I'd like to thank the members of the Vanderbilt Meharry Center for Excellence in Sickle Cell Disease. He just mentioned Dr. Kristen Washe, Dr. Lashana St. John, and I want to give special thanks to them because we worked together for the past 3 months in putting this together, and they really do a magnificent job. Once again, our amazing speakers, Dr. Shalana Station, Shalana Station, Marquise Moore, RK, I have the spelling here. Let me go by mine. I apologize because some of the names are a little unique. Wumi Bakari, and Dr. Stacy Martin. All of the patients and families for your participation. Without you, we could not make this day possible. And we look forward to seeing you next year. And I want to give a special thanks to Dr. Kassim and Dr. Ayatollah Kassim for all the work that he does. Dr. Michael Devon, I could not lead this foundation if it was not for working directly with them. And I just want to thank you all for all the hard work that you do and making my job a lot easier. So this has been an exciting day for me. And I just want to personally give a thanks to you all also. Kristen, I'll turn it over to you if there's any final comments.
That's all, folks. But right, we've been live streaming. We've recorded the day, so we've got videos from our sessions last year. I'm gonna hopefully in the coming weeks get video from today's sessions available, transcripts, Q&A. Like, there's so much information that y'all have provided today. We want to make sure that we are, able to get it out there because we're only scratching the surface here, right? But these few hours have passed so quickly. Thank you so much. And if you need anything, contact coalesce@vumc.org, or if you have my email, so whatever information there was, you can reach us there.
So let me just, before this, I should never do private business in public, but Michelle Salter or Michael Salter, I will be coming to London. So let's get together when I come out there, UK support group, so we can come up with a strategy to get more of your Londoners on this call and hear their viewpoints so that we can move forward together. And Reginald, I'll see you in Memphis in 48 hours.
Thank you.
All right, you guys take care.